So I did look up outcomes for short bowel syndrome over the break. We could not find anything specific about improvements with age or lack of improvement with age. We did find something related to gastrointestinal therapies for people with severe problems with their bowels, but there wasn't a ton of information either way, just to put that on the recording. So we'll go ahead and move on to stomatitis. Again, we're going proximal to distal, start with the mouth and move on from there. Stomatitis is a general term for inflammation of the mouth. All kinds of things can cause various kinds of inflammation of the mouth. It could be from bacteria, organisms, trauma, chemotherapy, really anything. It can be even idiopathic. One context in which we would use the phrase stomatitis would be acute herpetic stomatitis. That would be cold sores caused by the herpes simplex virus. So again, this is just a general term for mouth is inflamed for some reason. Moving on to the esophagus, we've already talked about how esophageal reflux can cause some heartburn, pyrosis, and referred pain patterns. So gastroesophageal reflux disease, or GERD, is a specific condition in which acid reflux is very, very common for that person for some reason. There can be a genetic component, it can be dietary in nature, it can be behavioral for alcohol or cigarette smoking, and it can be from conditions such as pregnancy as well. We talked about how pregnancy is going to physically push the stomach in that superior direction and physically push open into that space. A hiatal hernia, we will talk about, we'll have some images for that hiatal hernia right about here, would be another cause for GERD. Now, GERD is going to be a series of problems. Now, the junction between the esophagus and the stomach, we're going to have that junction where we're going to go from a non-keratinized stratus, squamous epithelium, to a simple columnar epithelium that's highly invaginated in the stomach and has many tight junctions to prevent the movement of acid beyond the stomach mucosa. They have very different forms, they have very different functions, right? With consistent gastroesophageal reflux, then we're actually going to mutate the cells of the esophagus into a simple columnar epithelium, similar to that which is found in the stomach. And we call that Barrett's esophagus. This is considered a precancerous condition for the most part. That's one of the reasons we're going to treat GERD so aggressively. It's not just mild heartburn, you're putting yourself at risk for cancer if it goes untreated. Yes?
Is this the one you were talking about, like when you swallow a Dorito now it's turned into a different kind of line?
Exactly. So there's the physical difference too of having, what's the purpose of a stratified squamous epithelium? Protection. It's many, many layers that are avascular. So swallowing a Dorito on this, you're going to scrape some layers of epithelium, you're going to be okay. Scraping layers of this with a Dorito, aside from it being precancerous, you're also probably going to bleed. So there's pain, there's also esophageal bleeds, which we really don't like. So there's a number of problems associated with this. Also with GERD, it's a downward spiral. You have a lower esophageal sphincter, also known as the cardiac sphincter, that's supposed to prevent the reflux of acid into your esophagus. Your stomach acid can actually wear away at that sphincter over time, making it even more likely to have reflux into the esophagus. Yes?
So the cells need to do something that store the acid or whatever.
Correct.
They're precancerous because it's a mutated cell?
It's a metaplasia. Those things had to mutate, and that means, and it's been exposed to constant damage that they're not supposed to experience. So both of those things are going to be representative of metaplasia. Right, it is adaptive. In its way, it is adaptive to the situation it's in. The situation is highly problematic, right? Yeah.
And why is it that, like, when you have heartburn, you're like, drink milk, or some sort of like take apple cider vinegar? Like, I understand milk that feels like, okay, that soothes it, but apple cider vinegar, it works. I've tried it, but
I'd probably recommend against it. Some of the arguments, I don't know entirely, but some of the arguments I've heard of that is that your body is going to balance your pH with things like bile. And so a lot of acids are going to act like bases in the body, and a lot of bases are going to act like acids in the body. just encouraging your body to release more alkaline fluid in response to that. If I was experiencing GERD, I would not be swallowing apple cider vinegar. Personal level. Yeah, that seems like a bad plan. That sounds terrible. It also has a lot of B vitamins. I don't know. I don't know why apple cider vinegar in particular. Um, yeah. Yeah. Follow your doctor's orders. Don't always listen to me about it. That's just what I've heard. But I haven't heard it from medical professionals. I've only heard it from the internet, which is very often wrong about things. Again, your doctor's probably not wrong. It's fine. What else do I want to say? We also worry about fibrotic scarring, which you know can cause dysphagia. Some of that stomach acid can make its way into airways, causing pulmonary symptoms as well. Let's take a look at that hiatal hernia I kept promising you. So again, we've got a respiratory diaphragm, and unfortunately we need to let things through that respiratory diaphragm in a few places. So you have a couple of hiatuses in your respiratory diaphragm. You have one for your esophagus called the esophageal hiatus. Here's how the fundus of your stomach should be resting against that respiratory diaphragm. The esophagus should be just coming through that hiatus, no problem. There can be a sliding hiatal hernia, where part of the fundus is going to herniate above the diaphragm, and now you're in the mediastinum, you're in the thoracic cavity. And then you can have even more of the fundus. A sacrum and peritoneum can go with it. So part of that, the membranous structures associated with your stomach would be dragged along with it. And again, pregnancy would be a great way to cause this if there's literally a growing fetus pushing against the inferior part of your stomach. We'll just physically push it up. Really wish I could find that video. Again, with hiatal hernia, there's probably going to be dysphagia associated with that. Probably, like we said, heartburn and chest pain associated with that. There could be other sources of intra-abdominal pressure increases. Your abdominal cavity is already very high pressure compared to your thoracic cavity. This is just air. This is stuff, right? But ascites is fluid in the peritoneal cavity. And we'll see a number of things that are going to cause ascites today. Obesity and chronic straining, as in constipation or coughing, could also increase intra-abdominal pressure. If somebody has a congenitally weak respiratory diaphragm, that's also going to increase chances of developing a hiatal hernia. Questions, comments? Okay. So we'll move on to ulcers. Your ulcers can be of the stomach. Your ulcers can be of the duodenum or duodenum. I think Jen pronounces it duodenum, so whatever. Peptic ulcers, you can have them in your stomach lining or intestines. This is a process by degrees. Now remember, this is a high acid environment, so your balance only has to be a little bit off in order to do this. I know you guys had microbiome. Did you guys learn about the guy who discovered that ulcers were caused by H. pylori? It's a great story. You would remember it. You didn't learn that story? That was it? Oh my gosh, it's such a good story though. Okay, so we used to think, oh, you get ulcers because you're stressed. And that's actually still kind of like the common knowledge. You're stressed out, so you get ulcers, right? So this guy's thought, I think it's bacterial, and I want to prove it's bacterial. The way he decided to prove it was bacterial was by drinking a slurry of H. pylori, and within weeks developing ulcers. Yeah. Right? He says it was a foul concoction. However, he got an award. He won a pretty major award, I don't remember which one, for proving that ulcers were from H. pylori. The end. Yes, this was post-antibiotic era. He was able to take antibiotics and cure himself of the ulcers, thereby verifying yet again that it was H. pylori. Yeah, no, it's gross. Hold my beer. Right. Gotta get this meth taste out of my mouth. So yeah, that's how we know that bacteria probably combined with environmental conditions, smoking, genetics, probably stress too. Why not? Having elevated glucocorticoids can contribute, but at the end of the day, you've got to have H. pylori to have that. That having been said, a lot of us are just going to have some local H. pylori hanging out. So again, this is a lesion that's going to be progressive. We'll have erosion of the mucosa. That erosion will turn into an ulcer as it reaches the muscularis layer of the stomach. And then the penetrating ulcer may make it all the way to the serosa, and you can have bleeding and other issues associated with that. There's a really old, I'm sure there are better pictures out there at this point, but this is the one from your textbook, scope picture of a duodenal ulcer. And again, a lot of them will be duodenal, a lot of them will be small intestine rather than being in your stomach itself, a peptic ulcer. Because your stomach's comfortable with stomach acid, your duodenum is responsible for, or not responsible, but it has the structures such as your pancreas and gallbladder that have the alkaline fluid that neutralizes the acid. So acid is not as happy in the duodenum as it is in the stomach. Okay, there are two major inflammatory bowel diseases. They're going to be ulcerative colitis and Crohn's disease. So when somebody is determined to have an inflammatory bowel disease, most pathologists are going to say, is it UC or is it Crohn's? That's sort of how that goes. And this was verified. They talked about it this way at the pathologist conference that I went to, is it UC? Is it Crohn's? Is it UC? Is it Crohn's? IBD itself seems like a larger category, but those are the most common. So ulcerative colitis is going to be related to chronic inflammation of the rectum and colon. Large ulcers are going to form in the mucosal layer of the colon and rectum. And if this goes untreated, then we're actually going to increase the risk of developing colon cancer, especially after 7 to 10 years of the disease. So strict management is important to prevent colon cancer. It's potentially related to a hypersensitivity. It's poorly understood, but probably a hypersensitivity disorder. Yeah. So let's try to differentiate Crohn's from ulcerative colitis. Crohn's is also known as regional enteritis or granulomatous colitis. It's more likely to affect the proximal portion of the colon, including the terminal ileum, which is the last segment of your small intestine. Instead of it just being about that mucosa, it's going to be about all of the layers of the intestinal wall. And the result is blockage of lymphatic vessels. Remember, we need those lymphatic vessels to absorb the fats. So we will have this sort of, I think of it as like a fatty appearance in our scope for this one. As we understand Crohn's disease, it's poorly understood again, probably autoimmune condition. Questions, comments?
So if it's autoimmune, is it something that, like, depending on outside, like, stressors and all that stuff that you could or could not develop?
Oh, so polygenic and multifactorial?
Yeah.
Probably. Yeah, polygenic and multifactorial, like all autoimmune disorders. Yeah, poorly understood. There's so much that we're just like, we don't know.
So we
Let's
say,
just
okay, that's fine.
let's just take out part of your bowel. That's fine, whatever. And different forms of enterocolitis, again, enterocolitis being the broad category. One form of enterocolitis is antibiotic-associated colitis caused by C. diff. And here's some great histology showing you the normal intestinal epithelium and how C. diff is actually just literally wrecking this intestinal epithelium with its bacterial toxins. I think that's great histology. This is why you had to learn histology, was that right there. So obviously if you have C. diff and you're literally your intestinal wall is being destroyed by toxins. Diarrhea, that's going to be exudative in nature. Abdominal pain, fever. Leukocytosis means overabundant white blood cells, possible sepsis, and possible colonic perforation in rare cases. I know you guys have heard of C. diff. You guys know about C. diff already. And the smell. Let's see. Apparently, a large percentage of people in hospitals carry the bacteria. Hooray. Another form of enterocolitis would be appendicitis. It's going to be inflammation of the vermiform appendix. That's going to be located off of the cecum of the large intestine. Yes. What is the appendix intended for? It's the purpose function. Previously, we used to say it was vestigial. We no longer really think it's vestigial. What we think the appendix is for is, you learned in micro about biofilms and how they're going to be resistant to removal, physical removal, antibiotics, everything, right? So you have your normal intestinal flora, right? You have your normal population of bacteria in your intestine, and it's going to help you ferment vegetables. It's going to help you process certain vitamins and minerals. You need them, right? They're your friends. They're your buddies. When they're a healthy population, they're really, really good. So think of it as like an apartment complex filled with great people that you love, right? No, the entire intestinal tract. Think of the large intestine as an apartment complex full of great people. And then severe diarrhea comes along, or an antibiotic regimen comes along. And in this scenario, all of that intestinal flora is flushed out. So suddenly everybody got evicted from the apartment complex. So it's possible that the new people who come into the apartment complex are still going to be wonderful people, but it's also possible that the new people that come into the apartment complex are going to be horrible people, a bunch of murderers, right? Like C. diff. So we would call that an opportunistic. It's going to be propagation of whatever bacteria are there. So one probable purpose for the appendix, and this is just a hypothesis, we've done some testing, it's looking good, is that it's a sort of biofilm of your own intestinal flora, your own bacterial population that can repopulate your large intestine after a severe bout of diarrhea or, in modern times, antibiotic use. And so then you get your good people again. What we do find is that every time you take antibiotics or have severe diarrhea, you do have less diversity of your intestinal flora. We like diversity in your intestinal flora. Having less diversity is not great. But it's better that to have a less diverse sampling of your own intestinal flora than to have opportunistic bacteria that arrive, show up from who knows where, from that cookie you ate off the floor, and and then you've got C. diff.
That just seems crazy because we know exactly what the kidneys do, we know exactly what the liver does.
Right. Well, we know that it's rich in bacteria. We know those bacteria don't like to go anywhere, but they're effectively a biofilm. And that's part of what makes it prone to infection, right? It's very bacteria rich. If you have, for some reason, predatory, I shouldn't say predatory, but noxious bacteria in there, then much more likely to develop appendicitis. It's a good question.
Would it make you less susceptible because you're not?
Not necessarily. If somebody's lost their appendicitis, then any bout of diarrhea or antibiotic use would make them more vulnerable to the bad bacteria. Yeah. Yeah, I've had appendicitis. I had mine removed. I took such probiotics after my last bout of severe and my last bout of, I had food poisoning a couple months ago. I'm still traumatized by it. and yeah, it's just daily yogurt since then. And my diet has changed since then too. I stopped, it's like I like the things that the bacteria like. I just like yogurt now. I just want yogurt. Can I just eat yogurt all the time? My diet's gotten less diverse. There's a lot of evidence that says your intestinal flora has a feedback loop with your diet. and your preferences, and even your maybe even mental health. We're looking into it. Obesity rates, all kinds of things are tied into your intestinal populations. They're right. Yeah, you can live without it, obviously. It's just that outcome. And I happen to know about that, so I got on the probiotics train early. For healthy, normal people, taking probiotics is probably doing nothing. Absolutely nothing. And sometimes worse than nothing, there's a new condition that's emerging. Again, poorly researched. We're just figuring this out. But some people who take probiotics who have a healthy intestinal system, the bacteria are supposed to be in your large intestine, not in your small intestine. And some people are getting like extreme small intestine gas as a result of taking extra probiotics that they don't need. And as soon as they discontinue probiotics, they're better. So if you're healthy, you probably don't need probiotics. If you're not healthy and you have reason to believe that you do not have intestinal flora right now, then probiotics are probably fine. There's also a lot of evidence that all of your probiotics are mislabeled with incorrect species labeled. All of them. Yeah. So don't trust what you're reading on the labels for probiotics. A lot of pseudoscience there. Okay, I'll move on. I think it's all clinically relevant, which is why I went on that tangent. It's tangential, but totally related to what we're talking about. Diverticular disease, remember we are talking about walls, we're talking about layers, and some of these layers can be fragile in nature. Diverticulosis is the development of diverticula. Diverticulitis is when those diverticula become inflamed. They are little pockets in your intestines. It could be because you have high intraluminal pressure. Maybe you are chronically constipated and you have stretched the walls, just like in your cardiovascular system, where you can have stretching of the walls of the tunics of your blood vessels, and that creates an aneurysm. The same effect could be happening in your intestines, especially in the colon, where is where you would most likely find these. And you just have a little pouch. That pouch can be a great little place for fecaliths to hide. Same thing with appendicitis, by the way. There can be something called a fecalith. A little piece of feces just impacts itself into the appendix and becomes infected as a result. Again, if that becomes inflamed, it's diverticulitis and fever, lower abdominal pain, leukocytosis, and you'll need antibiotics, and there may be a need for surgery for the abscesses. Obviously, the underlying cause is going to be that pressure from the lumen. That needs to be addressed too. So again, with the really ancient, like 1970s quality scope picture, I don't know why it looks like that. Questions, comments? Okay. Intestinal obstruction, a lot of the things that are going to obstruct the intestine are going to be, in some cases, feces, but in many cases, something to do with the intestines themselves. Some problem with the way that they are suspended or sitting, or the connective tissue of the intestines is really what's going to cause intestinal obstruction. So we'll talk about volvulus first. Now remember, it's not just a loose tube. You have mesenteries, like a double curtain, around your intestinal tract. Your entire gut tube is suspended by mesenteries. So it would not be normal for them to twist around because of the suspension. And also, if they twist around each other, you've got an additional problem of cutting off the blood flow through the mesenteries. You do have nerves, arteries, and veins in that nice fanned pattern in the mesenteries. So when part of your intestine circles and rotates around another part of small intestine, for example, then we're going to have ischemia. We're going to have a lack of blood flow to that part of the intestine. Common sites, cecum and sigmoid colon. You guys know what those are, right? Good, good. So we do worry about that necrosis that could happen in the bowels as a result of volvulus. For most of these, volvulus and intussusception, when we would expect that would be very young people, especially for some reason young males, toddlers. Little boys are more prone to volvulus and intussusception than any other population. Weaker, underdeveloped connective tissue, is one hypothesis. Why male, we're not really sure. Your daughter had it. I think you mentioned that to me. Mm-hmm. Mm-hmm. Yeah. Yeah, so a number of things can cause it. Again, much more likely in an immature person and a very young person, pediatric condition. It could happen to anybody, but it's likely. There's volvulus. Intussusception is a telescoping, where one part of the intestine is going to telescope into another part of the intestine. Here's another part. This is illustrating the ileum specifically, telescoping into the ascending colon. And again, we have mesenteries, so that's compressing the mesenteries on the way in and compressing that blood supply. Once again, most often in infants, males more frequently than females. You've seen it in weightlifters. That makes a lot of sense. A lot of herniations and displacement of intestine and weightlift. And I can see that. Yeah. You get it? Yeah, that's a good it. Yeah, that's why I took it from different resources for sure. Yep. So again, you've got mesenteries. They've edited out the mesenteries visually, which I think actually just limits your understanding of why this is so bad. Because I mean, you can still pass feces, right? That's not the problem. It's going to be the compression of arteries and nerves and veins. We've got an upsetting picture coming up. Hope you guys are prepared for it. Megacolon congenital or acquired, really what's happening, it could be from prolonged constipation, but there's a cause and effect issue that I think your textbook is not really getting at with megacolon. It could be that a neurological condition caused decreased large intestine motility and that caused constipation. Or it could be that constipation damaged the nerves and further caused constipation. So there are actually some really specific neurological conditions that lead to megacolon that we're simply not addressing. I just want you to be aware of that cause and effect relationship. Let's have a look at a horrible picture of a person who, in all likelihood, did not survive. And again, this is a severe case. Megacolon does not need to be this bad before it is addressed, be recognized. Yeah. It's a very good question. Just walking around, it happens. Definitely. Yeah, if you don't have health insurance, socioeconomic status, where you live, location, availability of resources, people listening to you and actually running tests. Absolutely. So I'll move on from that picture. So on to some malabsorption disorders. We kind of, for that section, we kind of made our way from proximal to distal, and we'll just kind of go back and do some cleanup topics for it. Remember, digestion is different from absorption. Absorption is about getting things like proteins, carbs, fats, nucleic acids across the intestinal epithelium. So if we have malabsorption for any reason, of course, our clinical manifestations, we're going to have osmotic diarrhea as a result of that. People are going to be passing feces that shows that it was not completely digested. There's going to be food products in there that still resemble food products at the end of the line. And of course, abdominal pain. And the causes are various. We have some things like celiac disease that we'll get into in a second, but it could be also surgical alterations if somebody has a shortened bowel, for example, or enzyme problems. Remember, an enzyme is a protein with a job to do. Enzymes are going to be the guys who are breaking down those macromolecules of life into monomers, right? And your enzymes are genetically determined. So you could have genetic conditions that mean you lack an enzyme. That means you don't break down this specific molecule, so that molecule stays the way it is across your intestinal tract, and you can't absorb it. So celiac disease is genetic. It is familial intolerance to gluten-containing foods. And again, gluten is one of those buzzwords that is very poorly understood. Very poorly understood. For people with celiac disease, any quantity of gluten is going to cause incredible amounts of intestinal inflammation that will degrade the intestinal epithelium. So instead of having villi, intestinal villi, those villi will be progressively destroyed, greatly decreasing the absorptive surface in the person with celiac disease. If they entirely avoid any quantity of gluten, even microscopic quantities of gluten, they can avoid the destruction of their intestinal epithelium. So a person with celiac disease, you cannot even make their gluten-free pizza on the same cutting board or on the same wood board that you made the gluten-containing pizza on. What's that? Yeah. It has to be completely separated from any trace of gluten in order for them to be safe. Same as a peanut allergy, just coming in contact with it. Yes. Gluten makes you fat. I've heard some good ones. I've heard that gluten acts like glue. Just because it has the sound glue in it does not mean that it is gluey in your intestines. No, that is also incorrect. Um, yeah, no, I haven't seen that sketch, but I've heard of it, and I've heard of things a lot like it. Yeah, there's some good ones. So, in some ways, you would think that this anti-gluten movement would be good for people with celiac disease. Oh, there's so much available gluten-free stuff. But it means that for the people who are just trying to decrease their gluten or avoid it, but are not literally going to be harmed by it, the safety precautions have decreased for gluten-free products. So somebody with celiac disease cannot trust a gluten-free pizza necessarily. No, absolutely not.
And is this going to be something that, like, internationally, they are just in, like, insurmountable amounts of pain?
Yeah. Oh, this would be very painful.
That could go on and they're like, man, I have a stomachache, but it's not like crazy.
There's definitely going to be some pain associated with that inflammation of the GI tract. It'll be visceral pain yet again. And let's see, what else do I want to say? Over time, as they do degrade those intestinal villi, that's going to be a malabsorption disorder, and it is once again going to lead to some osmotic diarrhea and some other problems. It's your body's response to gluten. You're going to have an immune response to the presence of gluten. Yeah. Can it show up later in life? Mm-hmm. Yeah, late diagnosis. I wonder. It could just be progressive manifestation of it. Maybe they had intestinal problems and they just were ignoring them. I'm not entirely sure. Yeah. Hooray. So yeah, it's difficult for people with celiac to win our current climate. And for somebody who does not have celiac disease, for most of the population, gluten's going to be just fine. That having been said, the idea of a sensitivity versus an allergy, in my personal opinion, we're up in the air about it. I think there's a possibility that food sensitivities exist without being a full-blown allergy. I've looked at the science on this because it has been frequently asked, and I'm very curious about it myself. We are looking at the inflammatory pathways of how we respond to an allergen versus there may be a completely different pathway for food sensitivities that would not register on an allergy test the same way. They might exist. We don't have a ton of evidence for them yet, but we're only just starting to look into whether a food sensitivity exists. And so I personally am not going to outright mock somebody who thinks that ruling out gluten has made them a healthier person. There could be other reasons that they're a healthier person, or food sensitivities might exist. We just, from a Western medical perspective, currently the answer to that is no. I try to be a little bit more open-minded than that because there's still research happening about it, and it's interesting stuff. Personally, I think they do exist. I think I'm sensitive to some foods. I drink milk and I break out like a 12-year-old. And I'm not allergic to it. I'm not lactose intolerant. There's something that happens though when I drink milk, and it's not the same pathway. So it just seems anecdotally to me that it exists. Yeah.
When I eat kiwis, it makes the top of my mouth, like the roof of my mouth, itch.
Yeah, I mean, kiwis make a lot of people itch. I'm not gonna lie. Avocados, yeah. My friend swears up and down she's allergic to onions, and she's just like, it just puts this disgusting flavor in my mouth, and I'm like, are you sure you don't just not like onions?
No, me too. I know what you're talking about.
No, yeah, no. It does seem to be something real. I just question it. Like I'm not subjectively experiencing it, so I'm just like, are you sure? But she tells all of the waiters that she's allergic to onions, and then she double checks when she gets her food that there's no onions. She's really serious about it. She says it upsets her stomach, and at this point I believe her, but there's definitely a period where it's like, she does detect it if you sneak onions into something. Really? Yeah, she does. And I've known her for like 15 years, and I still cook with onions, and I just forget. And I'm like, sorry, you can't eat this. Yeah. So yeah. I think there are, but science says no. That's where we're at right now. Okay, dumping system. Once again, going proximal to distal. Let's talk about your pyloric sphincter and how you have to have coordinated release of stomach contents into the small intestine. We want a little bit of a time to go into your small intestine. We want to be absorbing all of those macromolecules of life at a regulated rate. If we have deregulation of the pyloric sphincter, then we'll dump all of the stomach contents into the small intestine, absorb all of that glucose all at once, and then you're going to release all of your insulin all at once, and then you're going to have rebound hypoglycemia. That's the outcome of dumping syndrome. Again, why do you not have a pyloric sphincter working? It could be neurological. It could be because you had gastric surgery. It could be there were some ulcers around that pyloric sphincter, or there could be cancer in that region, and maybe it's not working or it's been removed. That would be why. And there's our short bowel syndrome that we've been talking about kind of all day. Most of this is going to be iatrogenic. What's iatrogenic again? No, that's idiopathic. We caused it. Some medication, some surgical intervention, in this case surgical intervention, we removed some portion of bowel, maybe a small part of the bowel, maybe a very, very large amount of the bowel. If you remove a very, very large amount of the intestinal tract, you are decreasing your absorptive surface considerably, and that can result in death, malnutrition, electrolyte and acid-base balance disorders, all kinds of problems as a result of that. Yes. Colostomy bags, very likely. Yeah. This one is showing you that it's not going to the rectum's been entirely removed, so that would have a stoma associated with it. Okay. And then, of course, you can have neoplasms anywhere along the GI tract, from esophagus to sigmoid colon, all the way down to anus. All of it could have a neoplasm. And once again, we're talking about neoplasms of various layers and of various depths and severities. Warning signs: black, tarry, bloody, or pencil-shaped stool, and a change in bowel and bladder habits are things that you're looking for as warning for cancers. Dysphasias as well, if you're talking about up towards the esophagus. Now again, since that GI tract, that gut tube is very long, we can remove segments, and you can be okay depending on how many segments and how much space you had to remove. And prognosis is just related to staging, as always. Esophageal cancer is of the esophagus. Gastric carcinoma. Gastric carcinoma is much more like occurs much more in Japan than in America. Who wants to guess why? Bombing of Hiroshima is a really good guess. Probably not that directly. Fishy diet. So mercury in fish is one strong hypothesis for why that. That's not to say we shouldn't all be eating fish. Fish is a very healthy source of protein overall, but environmental pollutants tend to, what we say, bioaccumulate in larger predatory fish. Happening in pescatarians, probably, yeah. Let's see. Small intestine neoplasms can be benign or malignant. When we do colonoscopies, one thing we're looking for is colonic polyps. They can be benign, again, or malignant. They can be like a precursor. Again, this would be a precancerous condition. So we would be looking for polyps in the colon on a colonoscopy, and then those would be biopsied intestine. So any protrusion into the GI lumen would be a colonic polyp, major precursor lesion to the development of colon cancer. A sessile polyp will be raised with a broad base, so just be sort of like a hill, whereas a pedunculated polyp is going to be on a stalk, and it's going to have a little stalk, and then it's going to be sitting out there. And then finally, colon cancer. Increased risk after the age of 40. A high-fat, low-fiber diet tends to be implicated. I wonder what kinds of fats, though. Presence of polyps, chronic irritation or inflammation for some other reason, and then hereditary risk factors as well. Have you guys heard about bacon and colon cancer before I put you on your next break? Don't go there. It's actually not as bad. It's something to demonstrate something that happens in science's reporting about how the risk of cancer is discovered and reported and then communicated to the public. So actually, when I started teaching was when the World Health Organization came out with this study of this deep meta-analysis that said, yes, there's a connection between bacon and colon cancer. And the answer was yes, there is a connection between bacon and colon cancer. And what they didn't report on was how that science works and how they came to that conclusion and what that increased risk looked like. So I don't remember the exact numbers, but basically if you eat a lot of bacon, your risk of colon cancer goes up for real. We have determined that it is a real increase in risk. And if you're really good at manipulating statistics, if you look at this number, what I've written on the board, this is not the real number, but I've written 0.01% chance of developing colon cancer if you don't eat bacon and a 0.02% chance of developing colon cancer if you do eat bacon. If you're really good at manipulating statistics, you can say your risk doubled. So when the World Health Organization says it causes cancer, it doesn't cause cancer, it's a 0 or a 1. It's a no, it doesn't, or it's a yes, it does. There is a real connection between bacon and colon cancer, but the actual risk, the absolute risk, is only very slightly higher if you're a regular bacon eater. And the science is trying to look into what part of the bacon is causing that. We think it's something to do with the nitrites and the nitrates in bacon, and there is such a thing as nitrate-free bacon. It could have something to do with the way bacon is cooked and those crispy bits that are so delicious may be the source of some of that. Same thing with like steak or any other kind of meat that gets crispy would have that same associated risk with it. So just be aware that that's what science reporting is. Take a look at the numbers. This is why you're going to take a statistics class, so that you can understand what we mean by doubling the risk, what we mean by halving the risk by taking a certain medication. It's not the absolute risk change may be very small, so it's always worth looking at that materials and methods section and looking at the numbers for yourself and understanding them so that you can communicate that absolute risk to people. Now I'll put you on break.